All right. Good morning, everyone. I would like to start. My name is Burkhard Mackensen. I'm an adjunct professor in cardiology. Originally, I'm a cardiac anesthesiologist who I also serve as the division chief for cardiothoracic anesthesiology, and I'm the director of interventional echocardiography here at UW, in case some of you may not know me yet. I have the distinct pleasure today to introduce the Grand Round speaker, who is a faculty in my department. Her name is Wendy Sure, and Wendy came to us about 6-7 years ago when I actually coincidentally at that time served as the interim chair. And we're very happy to have her join the department several years ago from South Carolina. Wendy, to give you a quick summary, did her training initially in Arizona for medical school, followed by her anesthesiology residency in Charleston at the Medical University of South Carolina. That's also where she served as an assistant professor in the department over there before she came join us. For several years now, Wendy not only has been a strong clinical faculty in our department, but has served as the director of our pre-anesthesia clinic. And as part of her interests, she's really focused on how to optimize patients preoperatively so that they can go through an operation with less complications. And more specifically, she's interested in the pharmacogenomics in medicine to see how preoperative knowledge about a patient's unique genomic pattern or picture could inform us how to best approach a patient. To give you a quick background, there's so many surgeries going on every year in North America, or in the US specifically. We're estimating about 40 million plus patients undergoing surgeries. If you think of that cost, it's about 450 billion. If you take those that have cardiovascular complications during surgery, we're thinking it's about 1.5 million a year. And the cost is estimated to be exceeding 25 billion. So suffice it to say that perioperative complications play a significant role for us from an anesthesiology point of view, but likely also for you, as you will always help us pre and post-surgery with these optimizations as well as with the complications that ensue. So without further ado, I want to give Wendy the podium. We will have a chance for questions to be answered, so please send them into the chat. And if you want to speak up later in the discussions, we'll make sure to unmute you. Good morning, everyone, and I look forward to Wendy's talk.
Thank you so much, Dr. Mackensen. I appreciate that nice introduction. And thank you all for having me at your grand rounds. I'm very excited to talk to you about the implementation and use of pharmacogenomics. So with that, I'll go ahead and get started here. So let's get back to the, okay. So I just wanted to briefly go over an outline of what we're going to talk about this morning. So we're going to talk about what pharmacogenomics is and what areas of medicine are using pharmacogenomics and what data exists for its use. And can we use pharmacogenomics in cardiovascular patients? And then how can we implement a program here at the University of Washington? So before we talk about pharmacogenomics, I first wanted to talk briefly about what precision medicine is, which pharmacogenomics is a part of precision medicine. And interestingly, in 2015, the Obama administration established a precision medicine initiative with a goal of bringing it to all areas of healthcare. And the NIH defines precision medicine as an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. And the hope is that this would allow physicians to predict a little more accurately which treatments will be best for their patients. And one of the goals of precision medicine is choosing the right drug at the right dose for the right patient. And this is where pharmacogenomics actually comes in. And we are going to talk a little bit about pharmacogenomics now. So the definition of pharmacogenomics is the study of how genetic variation in the form of polymorphisms and gene expression can affect an individual's response to medication. So in other words, how chromosomal variations affect the pharmacologic responses. And I just wanted to quickly review a couple of terms that are often used interchangeably, though historically they have different meanings. Pharmacogenetics versus pharmacogenomics. So pharmacogenetics is the influence of specific genetic variation in the population on response to a medication. And pharmacogenomics is the influence of an individual's entire genome on the response to medication. So we're looking at a difference in the level of application where pharmacogenetics generally refers to the population, whereas pharmacogenomics refers to the individual's genome. Okay, so this bell curve here is representing the idealized distribution of the response of the general population to any one drug. So you can see here the majority of people, about 66%, will have the clinically expected response to the drug that you prescribe. And then you have the outliers on either side. You'll have those patients that will have a suboptimal response and even a small group that will be non-responders. And then on the other side here, you'll have folks that will have side effects to that drug, and then those that will experience toxicity or adverse events. So pharmacogenomics is not a new idea. It was actually first described by Friedrich Vogel in the 1950s when he described the differences in acetylation of isoniazid, which is a medication used to treat tuberculosis. And these differences in the acetylation were due to polymorphisms that resulted in varying activation and responses of the drug. So he noted that the slow acetylators had increased toxicity and the fast acetylators had decreased efficacy. So when we talk about genetic variation, we're talking mostly about single nucleotide polymorphisms. And you can look at these polymorphisms in certain genes that are in the somatic line or the germ line. And when I say the somatic line, we're talking about those polymorphisms that are acquired, such as in tumors and cancers. And the germ line is those inherited polymorphisms that you're born with. And pharmacogenomics really focuses on genes that affect drug enzymes that affect the drug metabolism. These are going to be the CYP enzymes. You'll hear me talk about those a lot during the talk. And then also drug transporters that affect the ability of the drug to get to its target. Drug receptors that affect drug responses. And then the human leukocyte antigen, or the HLA, which is found on T cells. And drugs can bind the HLA and cause T-cell mediated immune responses, and we usually refer to these as adverse drug reactions. So a patient may be homozygous or heterozygous for the mutation that you find. And if they're homozygous for the mutation, it means that this mutation is on both alleles for the particular gene you're looking at. And this usually results in loss of function for that, let's say, enzyme. And if they are heterozygous for the mutation, then it's just found on one of the alleles for that gene and generally results in still having partial function for that enzyme, for example. Now, the genetic mutation that's present predicts the phenotype or the pharmacologic response. And it's important to remember that you can have more than one phenotype for any given gene that will affect the pharmacologic responses, because you can have multiple mutations on any given gene. And all the mutations will contribute to the phenotype, and all will affect the pharmacologic response. So you can use the metabolic activity to classify 4 distinct phenotypes for each enzyme. And you can use these phenotypes to guide your drug dosing. So essentially we're saying that the genotype is determining the phenotype, which is the pharmacologic response, basically. So these little running men on the graphs over here on the right are the 4 different phenotypes. And we're going to just use CYP2D6 as an example. This was actually first described for CYP2D6, but we now use these phenotypes for all the CYP enzymes. So here in yellow, you have the rapid or extensive metabolizer. And this is kind of a misnomer because these are your normal metabolizers. So if you have a patient tell you they're an extensive metabolizer of, say, opioids, it really means that they're a normal metabolizer. And then in green, we have the intermediate metabolizers that metabolize the drug a little bit slower than a normal metabolizer. And sometimes this can affect the pharmacologic response for certain drugs, and other drugs it doesn't have an effect. But we'll talk about that, the intermediate metabolizers and clopidogrel later on in the talk. And then you have the poor metabolizers that are going to metabolize drugs much slower than normal. And you can end up with either too little or too much drug in the system, depending on if you're looking at a prodrug versus the active drug. And then on the other end, you can have ultra-rapid metabolizers that are metabolizing drugs much quicker than they should, and you can end up having elevated levels of the active drug or no therapeutic levels of a drug, depending on if you've given a prodrug or the active drug. So I just wanted to run through an example here how you would apply these different phenotypes. So we'll use CYP2D6, and we're going to talk about the prodrug analgesics that are metabolized into their active metabolites. And some of those prodrugs include tramadol, hydrocodone, and codeine. So you would give the patient hydrocodone, and they would metabolize this into hydromorphone, which is the active drug. So if you have an ultra-rapid metabolizer, they're going to metabolize the drug much quicker than you would expect, leading to high levels of the active drug in the system, which can cause toxicity, or these types of patients we would see respiratory depression, significant respiratory depression to our opioids. Then you have the extensive metabolizers and intermediate metabolizers that will have no issues at all, as they will be metabolizing the drug as expected. And then the poor metabolizers here will metabolize so slowly that you won't have much active drug in the system, and that results in poor analgesia in this example. So it's important to remember also that if you're giving the active drug, it's going to be the exact opposite effect. So if you give the active drug to an ultra-rapid metabolizer, they metabolize it so fast you never get a therapeutic effect. And if you give it to a poor metabolizer, then you're going to get buildup of the active drug and end up with toxic levels and adverse events. But just to complicate things, the genotype doesn't always determine the phenotype. And this is termed phenoconversion. So phenoconversion is often seen in polypharmacy patients. And what happens is you end up phenoconverting extensive metabolizers, so normal metabolizers, to poor metabolizers due to a drug-drug interaction. And this actually increases the true number of poor metabolizers in the population versus those that are just measured by testing alone. And this is usually seen in the polypharmacy patients because they'll have one drug that will inhibit an enzyme that's used by another drug for metabolizing, let's say. And there are clinical tools out there that you should utilize if you have pharmacogenomics information. And the clinical tools are available online, and we're going to go through some of those resources for you, where you can look for these clinical tools, but they also have a lot of great evidence behind using pharmacogenomics to guide your therapy. So here's a list of 3 of the most popular resources and the most well-known. CPIC is at the top. Everybody that is studying pharmacogenomics will refer to CPIC, and that's the Clinical Pharmacogenetics Implementation Consortium. The website's listed there. And this is an international consortium of individuals and small group of support staff. They're interested in facilitating the use of pharmacogenomics in clinical care. And on their website, you'll see the list many drug gene pairs and the level of evidence that they have gathered for using pharmacogenomics to guide that therapy. And so that's a good place to start if you're interested in introducing pharmacogenetics into your practice, and see which drug gene pairs have good evidence behind them. And there's a lot of cardiovascular drugs on that list, by the way. And then there's PharmGKB, which is the Pharmacogenomics Research Network. And this is an online knowledge base that's funded by the NIH and maintained by Stanford. And then there's the Dutch Pharmacogenetics Working Group, the DPWG. And they're a multidisciplinary group that was formed by the Royal Dutch Pharmacists Association. And you can also access this site via the PharmGKB website. They do have some guidelines on their website, also in English. And you'll find guidelines on CPIC's website too. They have many published guidelines on different drugs. So if you're looking for evidence behind using pharmacogenomics for your prescribing, definitely look to one of these websites to get started. So now that we know what pharmacogenomics is, how do you obtain a pharmacogenomics profile? So first you have to obtain informed consent, just to obtain the sample and for housing the sample from the patient. Then you need to obtain the sample from the patient, and that's usually via a buccal swab or a saliva spit sample, depending on which vendor you're using. Some vendors will even send kits home to patients if that makes it easier for you. It's hard to fit this into your clinic workflow from experience, I could say that. And then you have the sample sent out to the lab for processing. You may be using an on-site in-house lab, or you might be sending out to a vendor, so that can affect the turnaround time, but typically around 3 days. And then the vendor or the lab will put together a pharmacogenomics report for you, and then you can use this report to guide your clinical decision making. And here's a sample report from one of our patients from the pre-anesthesia clinic. We had implemented a program in the pre-anesthesia clinic a few years ago, and we were using the vendor Sequentia here, so that's one of their reports here. And I just cut a few of the genes in that we were looking at, 60 genes, so I just included a few here. So you can see here CYP2C19, sorry, my pointer, CYP2C19, you'll have the result, the polymorphism that the patient has, and then you'll see what the phenotype is, and he's an extensive metabolizer for CYP2C19. So you wouldn't expect to need to change any dosages or medication choices for this gentleman if it uses CYP2C19. And then you can see here CYP2D6 has he's a poor metabolizer here. So he's one of those that we would want to think about avoiding using the active drug that goes through CYP2D6, for example. You wouldn't want to treat this gentleman with hydrocodone. You would want to treat him with hydromorphone, or else he's going to have no pain control. So that just gives you an idea of how you can use this pharmacogenomic profile to choose the correct drug and maximize that clinical response, and at the same time decreasing the adverse events. And this is a table that I put together that has all of the drug gene pairs from the CPIC website. that all have level A evidence. And when I say level A evidence, I mean those that have at least one prescribing action that CPIC recommends, and that it really should be used for prescribing your affected drug if you see it on the list. So I try to highlight some that y'all use, including clopidogrel and warfarin with CYP2C9, as well as VKORC1, and then the statins. So what areas of medicine are actually using pharmacogenomics? So we'll go through a few of those here. Oncology is probably the one area that's been using it the longest, and in most institutions around the country. I know we're definitely using it here. And you can look at mutations in the somatic line, which, remember, are those acquired mutations that are going to affect the underlying biology of the cancer. So these mutations are what drive the tumorigenesis. So you can actually develop drugs to those specific molecular targets to better treat the cancer. So for example, one of those drugs is crizotinib, and it is an anaplastic lymphoma kinase and CROS oncogene 1 inhibitor. So if a patient's cancer is ALK or ROS1 positive, then they would be a good candidate to be treated with this drug. And some of those cancers include non-small cell lung cancer, melanoma, and breast cancer. And then you can also use germline mutations that will affect drug responses and toxicity. And one indication here is to predict the toxicity to chemotherapy. So you can look at UGT1A1 and irinotecan, or DPYD for 5FU, and this is actually considered standard of care now, ordering DPYD before you are going to start therapy with 5FU, because this can be extremely toxic if you have certain polymorphisms, even leading to death. And then you can also use it to help guide your supportive care. So a lot of the patients end up with nausea from chemotherapy, and you can maybe look at the 5-HT3 antagonists and CYP2D6 to find out which one would work best for them. And then a lot of our cancer patients have significant pain, and looking at CYP2D6 and the opioids, as well as antifungals, as most of them are at risk of infection. You can look at CYP2C19. So psychiatry is also another area that's been using pharmacogenomics for a while now, maybe not as widespread as oncology, and they're mostly focusing on antidepressants. And you can look at the SSRIs and CYP2C19, and polymorphisms in CYP2C19 can affect the pharmacological behavior and can cause a decrease in the efficacy of the drug that you are giving, or even increase adverse events, including like arrhythmias. Same with the tricyclic antidepressants, looking at CYP2C19 and also CYP2D6. And tricyclics are used for depression, but also pain management, a lot of times in the chronic pain clinic. And polymorphisms can result in not having enough drug in the system, so you are not in the therapeutic range, especially in the poor and ultra rapid metabolizers. And when you see you could also see an increase in adverse events if you have a buildup of the active drug in the poor metabolizers as well. I just wanted to point out that there was a meta-analysis published in 2018 that did show that they improved remission and response rates in patients that received pharmacogenomics guided drug choices and dosing, which I thought was interesting. Sorry. Am I supposed to have a question right now from?
We can get to that later. Just continue.
Okay, sounds good. Okay, so we can also use it in acute pain, and this particular study is in perioperative medicine, which of course is my interest. And this was published in the American Journal of Surgery. And what they did is they always use an ERAS protocol for their colorectal surgeries and hernia surgeries. And they started using pharmacogenomics to guide their analgesic choices. And then they compared those patients to historic controls. So they were looking at 9 genes, several CYP enzymes that are involved in metabolism of opioids, as well as ABCB1, COMT, and the opioid mu receptor. And they either changed their dosing for the drugs, or they avoided certain drugs and substituted something else depending on the results. And they did see that the group with the pharmacogenomics guided choices had a decrease in analgesic consumption and a decrease in adverse events. It's not the best designed study, but it's a start. And then you can also use it for guiding your pain control in the chronic pain patients. So in this study that was published last year, it was a proof of concept trial, and it was done in chronic pain patients. And they took 235 patients in the pharmacogenomics guided treatment arm and 136 in the control arm. And they were looking at CYP2D6 here and using the phenotype to dictate which opioids they were going to recommend for those patients. And they did see a greater improvement in pain intensity from baseline in the CYP2D6 guided arm versus the usual arm, but only in the poor metabolizers and intermediate metabolizers that were treated with tramadol or codeine at baseline. And then 24% in the CYP2D6 guided arm had greater than 30% reduction in composite pain intensity, which is a clinically meaningful decrease in the pain world. So the question is, does it have a role in treating cardiovascular patients? Which is hopefully what y'all are interested in. So there are many cardiovascular medications with genetic determinants, including statins, which we'll talk about, warfarin, antiplatelet aggregation drugs, including aspirin and clopidogrel, and antihypertensives. Now, there's a lot less evidence for the antihypertensives than some of these others, but there is some tantalizing evidence for beta blockers, so we'll talk about those. So we'll start with statins. And as y'all probably know, the most common side effect of statins is statin-induced mild toxicity, including myopathy, myositis, and other muscle symptoms. And when patients experience these symptoms, it usually leads to non-adherence and sometimes discontinuation of the therapy. So if we want our patients to stay on the statin, which we probably would like, perhaps using pharmacogenomics to decide which would be the best for them would be a good idea. So we usually will look at the SLCO1B1 gene, which codes for an organic anion transporter. It transports the statins to the liver, and the 521TC is just an example of one of those polymorphisms. And what happens is if you decrease the ability to transport to the liver, you can't get the statin into the hepatocyte, and that prevents you from being able to lower the lipids and also causes statin-induced myotoxicity because you end up with systemic buildup of the statin. So there is a CPIC guideline published that actually suggests starting with a lower dose if the patient has one of these polymorphisms, or using an alternative statin. And this particular guideline is for simvastatin specifically, and then they suggest alternative statins such as rosuvastatin. And there are other polymorphisms also that are associated with lower LDL reductions, so not quite the response that you're expecting. And other genes are involved. I just don't have time to talk about them all, including ABCB1 and the CYP3A4 and CYP3A5 enzymes. Now, pharmacogenomics is used to guide statin therapy at several institutions around the United States, including Vanderbilt and the University of Florida. And at one of the institutions, interestingly, they will test patients that have risk factors for cardiovascular disease and thinking that they might need a statin in the future. And they will put the pharmacogenomics results into the medical record. And then when the physician goes to order statin therapy in the future, a little pop-up alert will tell the provider, based on these results, you should order this medication versus that one. Okay, so now let's talk about warfarin, which is a vitamin K antagonist. And it's prescribed to prevent thromboembolic events and to reduce the risk of MI. It does have a wide range of patient responses. And there is CPIC level A evidence for warfarin and CYP2C19, and they do have published guidelines. There's also FDA usage guidelines to help determine the optimal starting dose for warfarin. And the two genes we're going to focus on here, which have level A evidence, are CYP2C19 and VKORC1. So CYP2C19 plays a major role in metabolism, and there are multiple polymorphisms that are associated with a decrease in metabolism, which can lead to an increase in bleeding events. And VKORC1 codes for an enzyme that's responsible for the rate-limiting step in vitamin K recycling, and polymorphisms can increase the sensitivity of the patient to warfarin and may require lower doses to avoid adverse effects. Now, they in this Circulation article published in 2014, they did show that the use of pharmacogenomics could shorten the time to reach therapeutic INR. They also saw fewer extreme INR values and a shorter duration of low molecular weight heparin use during warfarin administration. And that was if they had a pharmacist kind of helping out with following pharmacogenomics results. Important to point out that there really is no large randomized controlled trials showing pharmacogenomics guided dosing improves anticoagulation control, though. So for clopidogrel, which is a prodrug, it is metabolized by CYP2C19, and a loss of function allele, so meaning the patient is a poor metabolizer or intermediate metabolizer of CYP2C19, these patients will have a poor response because they will not be able to metabolize the drug into its active form. So you won't have much active drug in the blood, which could lead to residual platelet aggregation. And then in patients that have a gain of function allele, meaning they're ultra rapid metabolizers, you could see an increased risk of bleeding because they have an increased amount of active drug in the system. So not only CYP2C19, but there are other genes involved with the metabolism and transport of clopidogrel. And the polymorphisms in ABCB1, which is, it codes for the MDR transporter, and it's responsible for intestinal absorption of clopidogrel. So polymorphisms in this transporter can cause greater efflux of the active metabolite, which can then cause lower serum concentrations and maybe just get a partial response to clopidogrel. And then PON1, which inactivates clopidogrel, polymorphisms can also affect the responses, but larger studies are needed to really flesh that out. And then enthusiasm's kind of waning for CES1, which is responsible for activating to the active metabolite also. And several institutions around the country are using pharmacogenomics of CYP2C19 to guide their clopidogrel therapy in the cath lab, and those include University of Florida, UNC, and the University of Illinois. And interestingly, at UNC, this This initiative was championed by a physician, and that was the director of their cath lab, and they successfully implemented this in the cath lab along with a little bit of pharmacy support. And then just to go through one big study looking at the pharmacogenomics for CYP2C19 and clopidogrel use. This was published by Cavallari et al. In 2018, and it was a multi-center pragmatic investigation that looked at CYP2C19 guided antiplatelet therapy after PCI. And they enrolled about 1,800 patients, and of those, 30% were had the loss of function allele for CYP2C19, meaning they were intermediate or poor metabolizers. And I just wanted to point out, in our 3,000 patients we had studied, we had about the same number with the loss of function allele. So 30% of our patients as well were not metabolizing clopidogrel adequately. And what they saw is an increased risk of major cardiovascular events if they were prescribed clopidogrel versus alternate therapy. So they saw 23 events per patient years versus just 8 in those with the loss of function. But interestingly, they saw no difference in the major cardiovascular events in patients without the loss of function allele and those with the loss of function allele, but the therapy had been changed. So as long as they weren't prescribed clopidogrel and they were prescribed an alternate therapy, then they had no change in the major cardiovascular events. And lastly, we'll talk about beta blockers, which we oftentimes will notice a variability in beta blocker response in patients, and that may be due to genetics. All of this evidence is kind of emerging, and we still need some more studies, but we'll go through some of them. So many beta blockers are metabolized by CYP2D6, including carvedilol, labetalol, atenolol, and several others. And what we find is in slow metabolizers, you will see elevated levels of metoprolol, which can increase adverse events like falls and hypotension. But in ultra-rapid metabolizers, you can see subtherapeutic levels and poor response to the drug. But you also have to remember, back to phenoconversion, we talked about earlier, that in our polypharmacy patients, oftentimes they're on antidepressants, for example, which are CYP2D6 inhibitors, and they can actually convert from an extensive or normal metabolizer to a poor metabolizer. So you may think that they're going to have a normal response to the drug, but actually they can end up with elevated levels of beta blocker because CYP2D6 metabolism of the beta blocker has been inhibited. And then they can experience those adverse events like the falls and whatnot. Okay, so we can look at one of the genes that's gotten the most attention is the beta-1 adrenergic receptor, the ADRB1. And there's two polymorphisms of note in this one, the 1165G and the 145G. And the 1165G polymorphism is associated with just a baseline increased risk of hypertension. Both polymorphisms will decrease the beta blocker response in the patient when you're treating them for hypertension. And beta blockers may not decrease mortality in these patients if they have one or both of these polymorphisms. I just wanted to go through a couple of studies here that looked at the beta blockers. So the first is the BEST trial, which is the beta blocker evaluation of survival trial. And they saw a decrease in mortality in the patients that did not have the 1165G allele when they were treated with bucindolol. But if you did have the 1165G mutation, you saw no reduction in your mortality at all if you were prescribed bucindolol. And then the SPS3 study, which was the subcortical strokes trial, they enrolled European and African people with a history of stroke, and they saw no association with the 1165G when looking at MI, ischemic stroke, and death. But they did find an increase by twofold, actually, in the patients that had the 145G mutation. But I also want to point out that there's conflicting data in the literature. So there's other studies that have concluded no link at all between these polymorphisms and cardiovascular events when treated with beta blockers. So additional studies definitely are needed to find out more information to increase the predictive power of the pharmacogenomics and beta blocker therapies. So now that we have a good understanding of the use of pharmacogenomics, how can we go about implementing a program here at the University of Washington? So how to get started? You first want to form a committee with a multidisciplinary team. This is about the stage we're at now. And you want your committee to include physicians, pharmacists, IT, lab medicine, maybe even genetic counselors and nurse educators. You also need to include support from the hospital. So executive leadership or medical directors are good to have on your committee as well, because it's going to take a lot of time and money to get a pharmacogenomics program started. So having the support from the leadership is key. Education is also so important. So you really need to have a robust education program. You want everyone to understand what pharmacogenomics testing is available and how they can actually use it. And so I just wanted to run through different ways that we could use to educate our clinical staff here at the UW. So we could start with online modules. We can either make them mandatory or just by choice if you want to do it. We can make it every year or twice a year, just something to keep everybody up on what pharmacogenomics is and how to use it. And you want the ongoing training to continue outside the online modules as well, such as through newsletters and seminars. But you want to make sure you're targeting each group with educating them about the implications in their field, or they're going to lose interest. You also want to use formal education, such as symposiums and grand rounds, as well as maybe resident lectures and seminars. And then it's also important to educate our patients and the public, educating them on how important pharmacogenomics is and how we can use it to guide our decision making when we're prescribing them medications. And we can involve our genetic counselors and pharmacists to kind of engage with patients and educate them. Then you have to decide who's going to, who will do the testing for us. Is it going to be an outside vendor as we were using in the pre-anesthesia clinic, or is it going to be maybe an in-house lab if you have the capabilities? And there's pros and cons to both for sure. And then you need to choose your drug gene pairs to start with. You want to start small. We started with a huge panel and it just kind of blew up in our face. So starting with drug gene pairs that have good evidence behind them, perhaps they have CPIC guidelines or their pharmacogenomics is included in their drug labeling. Maybe they're reimbursed by insurance, so you don't have to worry about the cost of ordering the test. Choosing those wisely up front is the key. And once again, looking at those level A evidence drug gene pairs from the CPIC website, you could just start with one of those or two of those. Then you need to think about the funding and reimbursement for the testing because it is going to cost money. So perhaps you have grants, that you can apply for? Maybe there's gifts and endowments at the institution, or are you just going to have the patient pay out of pocket for this? All things to consider. And then integration into the electronic medical record is so important. This is where we got stuck. I worked for 2 years trying to get IT to integrate our reports into the record, and it just never happened. And if it's not in the record, then nobody's going to be looking at it. And the reports have to be usable and accessible. Perhaps thinking about pop-up alerts for the physicians, so that can help them realize that there is a pharmacogenomics result for the medication that they're going to order, and then a clinical decision support committee making clinical decision support tools. When the pop-up comes up for the physician, it will kind of steer them towards which medication they should use and which ones they should avoid. So of course, there's a lot of barriers. I couldn't list them all, but some of the key barriers to actually implementing a program. Educating your physicians and patients are going to be so hard. To engage them is difficult. And you want to somehow improve awareness and understanding of pharmacogenomics to overcome this barrier. Implementation into routine. As physicians, we're all very, very busy every day, and we just can't imagine fitting one more thing into our day. So oftentimes, we're just resistant to changing anything. Access to results in the electronic medical record, we already mentioned. If they're not easily accessible in the medical record, we're not going to use them. You need tools to combine clinical and molecular information to design the clinical decision support tools, and this takes a lot of time, especially on the pharmacy side, that they may not have. The cost effectiveness, so who's paying for it? What's the cost of the test? Is it going to change outcomes? We know that performing one gene at a time is not cost effective, so you probably are going to have to look at multiple genes and broaden the implementation. And then there's the ethical, medical, legal issues, and this is actually what finally did my project in. Physicians are they ethically bound to look at these results? So if you've done the testing but they don't look at the results, is there going to be some sort of legal issue there? Or what if they're unaware that these pharmacogenomics results exist? I was doing these in the pre-anesthesia clinic, so folks in cardiology wouldn't have even known about the results since I couldn't get it into the medical record. So how do we overcome these barriers? So first, we ensure that we provide education for our clinical staff and patients like we already described previously. We ensure that pharmacogenomics is easy to use and fits into the physician workflow. So we make sure we have those clinical support tools, they're user-friendly, and it doesn't take a lot of time to take a look at the results and decide what you're going to do about it. You want to ensure economic value. So there was one systematic review that looked at about 80 studies investigating the cost effectiveness of preemptive pharmacogenomics testing, and it did show there was cost savings and that it was cost effective. So you also have to determine, are you going to do preemptive testing? Are you just going to test several genes for use later? Or are you going to know you have to prescribe, say, 5-FU for the patient, so you're just going to order that one test now because you know you're prescribing the medication now? Big decision. But probably preemptive testing makes more sense, so you know you have the result and you can test multiple drug gene pairs, making it more cost effective. And all these results are able to be used later in the future if patients are going to need new medications. So you want to choose the drug gene pairs wisely that you know are going to get reimbursed. There are particular genes that are always reimbursed with certain CPT codes, for example, CYP2C19, if you pick the right CPT code, or we also know that clopidogrel is always paid for. if you're ordering a test specifically to guide therapy with clopidogrel. And then you want to choose your patients wisely. So patients that might have difficult to control medical issues like, say, depression, and you have tried multiple medications and they have still failed therapy, you can convince the insurance company, hey, look, we've tried all these other drugs and none of them have worked. Can we please order the pharmacogenomics testing so we can figure out what might work better for this patient? So in summary, pharmacogenomics is one part of precision medicine, and it is used in many areas of healthcare. And pharmacogenomics guided therapy has been shown to increase patient safety by decreasing adverse events. And it has been shown to improve outcomes in patients with cardiac disease. And though there are many barriers to implementing a successful pharmacogenomics program, these barriers can be overcome. My references, and I'll take any questions.